to only hypertonia and hyperreflection. So the fasciculations that you can see and observe, the fasciculations here, C8,
Yes.
C8.
Yes.
So the diagnosis, lower motor neuron lesion. It's one of the important tests. There is a reflexes. Yes, my dear doctor, this is Station 3 Neurology, examine the upper limbs. My dear, listen very carefully. If the upper limbs are given here, so what we need to do, my dear? My dear, listen very carefully. Similarly, the same approaches means the type of the lesion, what is the lesion, and why is the lesion. Type is the UMNL and LMNL. UMNL means the HSCE, but in upper limbs, the hypertonia, hyperreflexia, not the clonus, not the extensor plantar, only hypertonia and hyperreflexia. And lower motor neuron lesion is the WWF, the wasting, weakness, and fasciculations. So that is the thing in a motor neuron disease, in the M and D, M for mixed UMNL and LMNL, and N for no sensory, no cerebellar, no extraocular muscles involvement. And yes, my dear, so these are the things that we're expecting. But yes, in upper limbs, we're expecting the lower motor neuron lesion is more predominant. Means the wasting and weakness is more predominant. So yes, my dear doctor, you need to do all the deep bundle backs all together, greetings, introduction, instruction, pain, position, and posture all together. And after that, you'll start your examination and you need to examine him very carefully. And examining him, that is obvious that we can see the wasting of the muscles, especially the guttering here, the distal group of muscles, and also the proximal muscles as well. The wasting, and also he has got the weakness, but the more on the distal weakness is more predominant. And over the wasted muscles that you need to do, and we can see some of the fasciculations here and here. So the fasciculations that you can see and observe, the fasciculations here. So now, my dear, listen very carefully. You can start your examination. The motor examination means that you need to know that you found that the wasting, weakness, fasciculation is the lower motor neuron lesion, and the motor examination starts with the tone power reflexes. And definitely for the tone is a hypertonia that you can expect. So yes, we can see that this is really hypertonia. Yes. Now on the left hand side, that we can feel some of the resistance that yes, it's really difficult. So the hypertonia that we can feel. After getting the hypertonia, now the reflexes that we are expecting, the hyperreflexia. Yes. So yes, the hyperreflexia that we can find in here, also hyperreflexia that we can get the hyperreflexia for the biceps, as well as you need to see the triceps as well. So yes, the hyperreflexia that we can find, and also here the hyperreflexia that we can find here, and also the yes. So these also yes, this is hyper yes. The hyperreflexia that we found. So now, immediately after the motor examination, you need to do all the motor tests, my dear. Because of the weakness, just we avoid the finger nose test for the coordination. But we found that he has got the hypertonia, hyperreflexia, and also the power test that you must do, my dear. So we found that he has got the hypertonia, hyperreflexia altogether. And also he has got the wasting, weakness, and fasciculations altogether. And immediately after that, the sensation that you need to do, that the joint position sense and vibration senses for the dorsal column sign, and also next the spinothalamic tract sign, that is the cotton wool test and the pinprick test. So now we are doing the joint positions intact, but I'm just showing the vibration senses. So sir, are you feeling?
Yes.
Now I'm putting in the different places of your hands. So if you feel, just say yes. All right. Now close your eyes. Are you feeling?
Yes.
Excellent. Are you feeling, sir?
Yes.
So his vibration sense is intact, means the dorsal column is intact. Immediately after that, the spinothalamic tract sign, that you have the cotton wool and the pinprick. So yes, I'm just avoiding the cotton wool, but you need to do that, my dear, for the pinprick test, my dear. So similarly, the dermatomes is really important. We know the C6 and these three, the 3 C7 and the C8. C6 altogether is the C5. So C5, C6, C7, C8, and then T1 and then T2. So similarly, so are you feeling?
Yes.
This is sharp. You need to educate your patient. This is sharp. If you feel then say yes. If you don't, say no. I'll put it in different places of your hands, my dear. Now close your eyes. So now tell me.
Yes.
Excellent.
Yes.
So this is C5.
Yes.
C6.
Yes.
C6.
Yes.
C6.
Yes.
C7.
Yes.
C7.
Yes.
Excellent. C8.
Yes.
C8.
Yes.
This is T1.
Yes.
This is T1.
Yes.
So, means the cotton wool and the pinprick, means the spinal tract sign, also intact. It has mean that all the modalities of sensation is intact. So what we found, my dear? We found in his case, the putting all them together, the sensation is intact, means no sensory involvement. So my dear, listen very carefully. Whenever you finish your case, you need to wash your hands, give the good thanks to your patients, and immediately after that you come forward to the examiners and always say the 3 important bundle packs, my dear. I'd like to finish my full examinations of the neurology by examining the lower limbs, cranial nerves, and also the higher psychic function and cerebellar syndrome. And I'd like to finish my full examination by checking the observation chart that includes the pulse, temperature, respiratory rate, and oxygen saturation. And also, I'd like to do the urine distillate for the sugar, protein, RBC nitrites. Saying these 3 important bundle packs, it does mean that you finished your full examination and you'll get the full marks in examination section. Immediately after that, you need to present your case, my dear. So, sir, my clinical diagnosis of this gentleman is upper motor neuron lesion affecting the both upper limbs, as evidenced by hypertonia and hyperreflexia, and also along with the lower motor neuron lesion, as evidenced by wasting and weakness and fasciculations, and wasting and weakness predominantly on the distal part and also the proximal parts as well. But yes, the distal part is more affected. So my clinical diagnosis of this gentleman is mixed upper motor neuron lesion and the lower motor neuron lesion. Now I think the lesion is in the anterior horn cell, and the underlying etiology of this mixed variety of upper motor neuron lesion and the lower motor neuron lesion is anterior horn cell disease, as evidenced by there is no sensory involvement, as evidenced by all the modalities of sensations are intact. I'd like to assess, especially to look at the bulbar palsy and to examine the cranial nerves, and also to examine and also to measure the bedside forced vital capacity in lying and sitting or standing position to see any of the discrepancies, so that I can assess this gentleman has got the significant diaphragmatic weakness. And I'd like to confirm my diagnosis, because it's a strictly clinical diagnosis. I'd like to exclude the other possible differential diagnosis by doing the scan, MRI brain and the spinal cord, to exclude the multiple sclerosis and also other spinal cord pathology like the CMFAS, means the cervical myelopathy, multiple sclerosis, Friedreich's ataxia, and cervical combined degeneration of spinal cord and hypoparesis. And also I'd like to do the scan, means the MRI brain, especially to look at the cerebellar syndrome, to exclude the other differential diagnosis, and also to do the EMG and nerve conduction study to exclude the nerve disease, means the motor nerve disease, and also the motor neuropathies, and also to exclude the neuromuscular junction disorders. So saying them, my dear, yes, I think the patient, the examiner will be happy with this case, my dear. Immediately after that, maybe other questions can be asked, but I hope that having this case, my dear, you enjoyed a lot. But my dear doctor, listen very carefully. One of the most important part that I'd like to add here, this gentleman is not having involvement with a bulbar palsy. Bulbar palsy means the bulbar and the pseudobulbar palsy. Sometimes the cases will be given in your exam that the case, maybe the neurology, examine the cranial nerves. So examine the cranial nerves, you will do all the cranial nerves altogether, but the findings that you need to do, the 3 important tests to get the findings and the diagnosis of the bulbar and pseudobulbar palsy. Now let's have a look on his case. So starting with the most important, the tongue, my dear. Have a look for the tongue. So the bulbar and pseudobulbar palsy, my dear, listen very carefully. What you need to do, you need to tell him, sir, could you please just stick your tongue out for me? So what you're looking for, you need to look for, if you're getting the WWF, means the wasting, weakness, and fasciculations. If you get the tongue, yes, if you get the tongue is fasciculating tongue and having the wasted tongue, so the diagnosis, lower motor neuron lesion. In contrast, means the bulbar palsy. In contrast, if you're not getting the not wasted, not having the fasciculations, so diagnosis, upper motor neuron lesion, means the pseudobulbar palsy. In bulbar palsy, you'll get the wasting, weakness, and fasciculations. So immediately after that, this is one of the important points, that the tongue, that what you need to do, you need to tell him, sir, could you please just say a big for me? Say once again. What you're looking for, we are looking for the palatal palsy. Big say for me. So if the palatal movement is absent, then you can see the palatal palsy in both cases, in bulbar and pseudobulbar palsy. Immediately after that, the tongue and the palate that you need to test for the speech quality, my dear. Sir, could you please tell me your name?
Dejaul.
So in case of bulbar palsy, there's a lower motor neuron lesion, that you can get the nasal tonation, like Dejaul, something like that, nasal tonation. In contrast, in case of pseudobulbar palsy, you'll get the spastic type of voice. We call it the harsh vocal quality, harsh quality. So yes, my dear, sometimes it's very difficult in the exam, but you just test it, just having some of the name, that's his test, my dear. So the tongue and the palate, and immediately after the speech, and most important, one of the important tests, there is a reflexes. The reflexes, we're expecting the hyporeflexia and hyperreflexia. In bulbar palsy, hypo, in pseudobulbar palsy, the hyperreflexia. Like you need to tell him, just could you please just slightly open your mouth and to put your hands here and you need to tap here. So if you found the normal or maybe reduced, means that this is the bulbar palsy. But if you're getting the hyper like this, so definitely this is the pseudobulbar palsy. So I do once again, I'm just revise the things once again. Just stick your tongue out for me. So we are looking for wasting, weakness, and fasciculations for the lower motor, means the bulbar, and non-wasted and the non-fasciculating tongue, the pseudobulbar palsy. Sir, could you please say for me? Take the thoughts and to see the palatal palsy in both cases. And could you please say your name, sir? Name?
Dejaul.
So yes, just to see the nasal intonation for bulbar. If not nasal, this is a spastic variety. And then the jaw jack, and this is the jaw jack, means the absent, means a hyporeflexia for bulbar and hyperreflexia for pseudobulbar palsy. But my dear, listen very carefully. In a motor neuron disease, the findings that you are expecting, definitely the mixed variety. Mixed variety means we'll get the findings in the tongue, especially the wasting, weakness, and fasciculating tongue, along with that palatal palsy, along with that, the hyperreflexia means the jaw jerks is hyper. So this is the typical findings that we're expecting in a patient with a motor neuron disease. So yes, my dear, sometimes in the exam, like the cranial nerves examination, that you will get these mixed findings. So yes, you must make your diagnosis, the first diagnosis, my dear. The motor neuron disease means the anterior horn cell disease in a pseudobulbar or bulbar or mixed variety. So yes, my dear, having these talks, I hope that if you have the features or if you are instructed to go for the cranial nerve examinations, so definitely you have these findings so that you can make your diagnosis, my dear. So my dear doctor, listen very carefully. Now summarizing here, we found, or you are expecting the findings, that the mixed variety of bulbar and pseudobulbar palsy is evidenced by the wasting, weakness and fasciculating tongue, and also the palatal palsy, and also pseudobulbar palsy is evidenced by the hyperreflexic, that is the jaw jerks, in the cranial nerve examinations. And in the upper limbs that we found, the predominantly low motor neuron lesion is evidenced by distal wasting and weakness, both the proximal and distal, but the more predominant distal wasting and weakness of the muscles of the hands especially, and along with that wasting and weakness and fasciculations altogether. And also here is also the upper motor neuron lesion is involved, the mixed variety, and that is evidenced by the hypertonia and hyperreflexia, but without any sensory involvement. And in the lower limbs, similarly, we found the upper motor neuron lesion is predominant picture as evidenced by the spastic seizure gait. Along with that, the hypertonia, hyperreflexia, clonus and extensor plantar is a predominant pictures. Along with that, the lower motor neuron lesions also as evidenced by the wasting and weakness and fasciculations altogether, and with no sensory involvement. So here, the cerebellar syndrome is the cerebellum is not involved, that we can do the test. Because of the weakness that we are not able to do the test for the cerebellar syndrome, but in the eyes that you can see the nystagmus, the 5 other features that you can do miter, but there is no nystagmus here. And also there is no extraocular muscles involvement. So that is the most important point that you can see that, can you just follow my finger? Just follow my finger. So we can see there is no nystagmus here. No nystagmus, and you can do the H movement for extraocular muscles involvement. And there is H movement for extraocular muscles involvement. Yes. So the H movement. So there is no involvement of the extraocular muscles involvement as well. It does mean, this is very much important, that no sensory, no cerebellum, and no extraocular muscles involvement. So we can exclude the diagnosis and other differential diagnosis. So this is a motor neuron disease is a consistent diagnosis. So yes, my dear, having this knowledge, I hope that if you have a case, my dear, definitely you will do the best. The case is really important, the discussion is really important, and I hope you've enjoyed a lot, my dear. Thank you very much.